Claire Robertson, as you've all gathered. I'm a consultant physiotherapist in patellofemoral pain. And just a little bit of background without boring you, hopefully. I qualified in 1994 and went on from being a clinical physiotherapist to become part researcher, part clinician. And all my research is driven by things I see clinically that make me scratch my head, look at the literature and realize there's a gap in the literature. And I'll be talking a little bit about that during the talk. And I teach on patellofemoral pain as well. So all things patellofemoral pain. And I was telling Tarina, I've actually recently crossed the 10,000 patient mark who's got patellofemoral pain. So you name it, I've seen it with patellofemoral pain, I think. But today is a slightly unusual talk, one that I wanted to give because I think there's some really interesting and useful lessons. So I'm talking about patellofemoral pain, but reflecting on it and looking at the lessons that we've actually can perhaps draw from the experience the last 2 years. And actually I was thinking this morning, it's actually 2 years this month since certainly COVID had a huge impact in the UK and started the first lockdown. So what are we going to look at? Well, we're going to look at the emerging, and it really is very emerging, unsurprisingly, but emerging literature on post-COVID-19 musculoskeletal pain. And I want to really reflect around patellofemoral pain and what I've observed and seen in my patients coming through, how things have changed and why, and what I've reflected on and what perhaps we've learnt from that. And I'm particularly interested to look at 3 areas, therefore: load, conditioning, and anxiety. And we're going to try and put that together with the evidence base and the literature that's already out there on patellofemoral pain. Perhaps unsurprisingly, there isn't any literature yet on patellofemoral pain and COVID. So what I'm doing is really using clinical reasoning, using reflection, and marrying that with the evidence base that we already have. Okay, so let's just think, I love this quote by Johns, 2004, reflective practice is the antidote to complacency, habit and blindness. And as I said at the beginning, you know, I've been qualified nearly 30 years, and people say, oh, don't you get bored of seeing patellofemoral pain and that's all you do? And I never get bored, because I hope that I'm constantly evolving, and a big part of that is reflection. And I know there's quite a few students on the call, and it's very easy to think of reflection as this thing that's taught at physio school and that we have to do as part of our course, but actually it's a really essential part of evolving as a clinician. And I've really used that reflection and really try to dig deep and think deeply about what I've experienced with my patients in the last 2 years to try and write this talk. And I think on reflection, the things that really came out as the emerging themes, it wasn't a thematic analysis, but in sort of informally, were anxiety and depression, loss of strength and conditioning, load, changes in load, running volume, and footwear. And these are some of the things that I'm going to be talking about today. So actually what I want to start with is ironically not written for patellofemoral pain, but I love this model, and I think that it's a really nice way of thinking about patellofemoral pain. And apologies to anyone in the audience who's heard me talk before, because I tend to always come back to this model, because I do really think it's a lovely way to frame how we think. So let's just stop and look at this model and see what it's all about. So it's called the Pain and Movement Reasoning Model. And as you can see, it's a triangle. So if we think about it with respect to patellofemoral pain, the bottom right-hand corner, local stimulation. So that the patellofemoral joint might be subchondral bone edema. It might be ischemic change in the parapatellar soft tissues, might be edema in the fat pad, might be a bruised patella from a fall onto the knee. It can be anything that is local to the knee. Now let's look at the bottom left. So the bottom left is regional influences, and really the last 20 years the evidence base around patellofemoral pain has very much sat here. So looking at the role of the foot and excessive pronation, looking at femoral anteversion, looking at femoral internal rotation, looking at pelvic position, trunk, and how these regional things will influence the patellofemoral joint and the load that goes through the patellofemoral joint. But then the top of the triangle is quite different. The top of the triangle in this model is CNS modulation. And in this instance with patellofemoral pain, this might be thoughts, beliefs, emotions about the pain. I've done a lot of work on crepitus and published on crepitus, and that was all emerging thematic analysis on beliefs about the noise. It might be, as it says, there's current social context. It might be a teenager who's on a sports scholarship and they're worried because they can't do their sport. It could be a young mum who wants to get fit again after having a baby and is struggling to get back to running. She's sleep deprived. So anything that may affect the CNS. And as those of you that are treating patellofemoral pain will know, often these patients have had their symptoms for a long time. And what we know from the pain literature is the longer the duration, the more likely there is to be change in the central nervous system. So what they suggest in the model is that you think about these relative contributing factors. So if we had someone that had just fallen onto their knee 2 weeks ago, banged their knee, and they were bruised and swollen, they weren't catastrophizing, okay, your cross that you're going to put on your triangle might well be in the bottom right hand corner. But it's pretty unusual. Most of the time we've got an insidious onset scenario. There might be quite a lot of regional biomechanics that you think might be feeding in and be risk factors for patellofemoral pain. And of course, if we've got lots going on at the top of the triangle, our cross might actually be further up the triangle. So it's a way of thinking about these different elements without overcomplicating. And I want you to keep this in your mind throughout the talk, because we will be featuring different elements of this triangle and reflecting on what we've seen and what's happened to these elements of the triangle during the pandemic. Okay, so let's start with the top of the triangle. So that was CNS. So just before the pandemic, this wonderful paper came out by this author, Ride, in the UK, looking at anxiety and depression in patellofemoral pain. So as I say, this was pre-COVID, and it was a large study. They managed to get 400 completed questionnaires, and they were really screening for the presence of anxiety and depression. They weren't looking at causation. They were just looking at it in patellofemoral pain subjects. And the statistics are interesting. So we've got a prevalence of anxiety of pushing up to 50% there, isn't it? 49.5% demonstrated anxiety and 20.8 indicated depressive symptoms. So this is measurable anxiety and measurable depression using validated scores. So to contextualize that, in the UK, if we look at figures for the normally in the population, the non-patellofemoral pain population, we're looking at anxiety around 6-7% and depression around 3 to 7. So clearly these figures are much more elevated in this population group. Now, the remit of the paper wasn't to say if you're anxious, are you more likely to develop patellofemoral pain, or if you develop patellofemoral pain, you're more likely to become anxious. That wasn't the remit of the paper, and we can't draw that causation from this paper. But what we can draw is an awareness that in our population of patients with patellofemoral pain, anxiety and depression features as are very regular. I mean, every other patient you see is going to have demonstrable anxiety if you measure it. So that is something we need to sort of absolutely raise our awareness of. So how does this link in with COVID-19 now? Well, what we can see from this first paper, and of course all these papers are very recent, is that there is now plenty of literature. I mean, this paper is 2020, there's been more since, demonstrating, and this won't be a surprise to you, an increase in anxiety and depression across the population, not obviously just patellofemoral pain, during the pandemic. And then for those patients that wanted to seek treatment, in this case for patellofemoral pain, it's been harder to access services. So that beautifully heightens anxiety. And of course, long before COVID, we knew that anxiety and depression can really increase pain through poor sleep quality, which we need good sleep to downregulate pain pathways. And this last paper here, Cristofaro, I mean, it's a big survey, 1,872 patients, showed that in the pandemic, during the pandemic, those that were inactive were more likely to be depressed and more likely to have musculoskeletal pain. So we're getting a picture here, aren't we? The whole population, the population as a whole, is more anxious and depressed. Those seeking treatment are not being able to access it, are getting even more anxious, driving poor sleep, and the prevalence of musculoskeletal pain is going up. So we absolutely need to be thinking about this. So should we concern ourselves with this? And can we do anything about this? Absolutely, yes, yes, yes. We need to have this on our radar. So first thing, as always, with everything, once you have something on your radar, you're more likely to spot it. So be aware, have it as something that you're very consciously thinking about. And this isn't just for your patellofemoral patients at all. So what do we do then? Well, we can measure. And it's always good, of course, to be using validated outcome measures. And the one that I use is the Hospital Anxiety and Depression Scale. It's easy to use and it's freely available as well. So I would be looking, and of course I don't measure this on everyone, but if I do start feeling with a patient that this is a particularly strong feature in the top of the triangle, my mark of what's relevant might be quite near the top, I might be tempted to measure so that we can see where that result is. So in line with this, let's think about sleep. There's lots of work, and this again, of course, predates COVID, but there's escalating work now around sleep. It seems to be a real area of growth, which is great. So there's plenty to show that the relationship between sleep quality and pain perception is tight. So in line with this, I ask every single patient about their sleep quality. Is their sleep disturbed? And if so, why? It might not be because of their knee pain, but even if it's, so say, for example, someone's got a young baby, or they're very anxious, or whatever it may be, even if it's not sleep disturbed by the pain, it's still relevant for the pain because it's going to alter their pain processing. And COVID specifically, I think, has disrupted routines so much. So, you know, people have lost that sort of regular routine that they perhaps had of getting up, commuting, going off to work, coming back, maybe doing some exercise. People have lost the commute, which in some patients, of course, is an active commute. So even if they're not a regular exerciser, they might have walked half a mile, perhaps, to the station each morning and evening. So they've lost a mile of walking. And I think the whole working from home thing has really disrupted people's routines around potentially what time they get up, what time they're eating. People's routines have really altered. And for those that haven't had to sort of a reason to get up and out of bed, it's been reported that people are sort of, you know, hanging around in bed for longer. And actually that is been clearly shown as one of the worst things that you can do if your sleep is affected. So, these might be basic measures, but these are useful things to know to be able to talk to your patients around. And if patients are feeling anxious, at least listen to a really interesting podcast by a sleep expert around anxiety and sleep. And she was saying, look, if you are really anxious for whatever reason, get up, move away from the bedroom, write down all the anxieties, and then go back to bed. And the chances are then having that sort of brain dump sort of almost frees up the ability to then go back to sleep. And of course, exercise. And, this is something I've always found with my patients, is that a lot of them, the pain has come on from exercise, from something they're doing, whether it be volume, duration, form, something to do with their exercise has kicked off the patellofemoral pain. So you've then got a scenario where a regular exerciser has stopped exercising. And of course, in the pandemic, there were lots of people that found that their sporting facilities, their tennis club or their gym or whatever it was shut. So their exercise profile really dropped. So from a sleep perspective, this can be really bad news. So what I've tried to do is assess for that. And if I feel that is, if they've lost exercise and they've got poor sleep, okay, now the gyms are back open, right, can we get them doing an upper body program in the gym? Or perhaps if the gyms are shut, or the exercise facilities are shut, whatever it may be that they're doing, can they even manage some light exercise, fresh air, and just an evening walk, say? And obviously it's contextual, and thinking about all of you all over the world listening, of course, you will all have different setups with respect to what exercise your patients are doing, in what facilities, in what climates. So of course you have to make it bespoke to your setting, but I'm trying to highlight the importance of asking about sleep and then helping your patients come up with some common sense, pragmatic strategies that they can utilize, which helps to stop them tipping into chronic pain, which so many of these patellofemoral pain patients end up. Okay, and now I want to talk to you now about this won my Paper of the Year award in 2020. So this paper looked at teenagers, adolescents with patellofemoral pain. And Selhorst, who's a physio, teamed up with a psychologist to do this study. And what they did was they took a psychological model. I like the name of this, it's my kind of thing, common sense model of self-regulation. So they took this model and they looked at the dimensions of the model. So bear in mind, it's a psychological model, not a musculoskeletal one. But we can look at these 5 and we can apply these to anything. But let's, in this instance, apply it to patellofemoral pain. So identity. So in other words, right, here's the knee model. I'm going to explain that this is the patellofemoral joint at the front. So what is it? So explaining about the patella, the trochlea, not in too much detail, just enough that someone has a concept of, okay, this is something going on at the front of my knee. Cause. My research has dug deep into the health beliefs literature and has shown that when people have insidious onset, they find it much harder to engage with their treatment because they can't quite get their head around why it's come on. If you have a football tackle and you rupture ACL, it's obvious why it's happened. It's obvious what the course of treatment is, surgery, whatever, rehab, and there's a time frame. It's quite clearly mapped out. When something's just crept on, it's really difficult to engage and get your head around it. So I personally think this second element is a really important part of this model. So cause, in this instance, it might be, okay, you've changed jobs and you're now on the 4th floor and you're doing a lot more stairs. Or, okay, in COVID situations, right, you've lost the use of the gym, you've got weaker, and that loss of strength meant those very mobile patellae are a little bit more mobile than they were. So helping the patient get their head around it and go, okay, right, that makes sense. Timeline. So, why would someone know how long it lasts? Is it going to last a week, a month, a year, forever? So helping them understand okay, so we think we need to get you stronger. So we're going to go on a 6 to 12 week strength program to get meaningful strength gains. Consequences. How could it impact on their life? So should they let it impact on their life? Should they stop all their sports? Should they carry on and ignore it? Helping them, guide them with really load management and understanding. And in line with that, controllability. So this last feature of the model. Is it possible to have any controllability? Absolutely, yes. Let's empower our patients. Let's give them the locus of control here. So they are the 5 parts of this model. So what they did was they made an 8-minute video of patellofemoral pain in non-scientific language for the adolescents, featuring these 5 concepts. And just before the video, immediately after, and 2 weeks, they did some measurements. So let's look at what they looked at. So they looked at, and here are the results, pain catastrophizing, 47% less at 2 weeks. Fear avoidance, 54% less at 2 weeks. Kinesiophobia, 33% less at 2 weeks. And statistical reduction in this score here, measuring function, which at 7.5% again at 2 weeks, and the visual analog score as well, 21% improvement at 2 weeks. Now just pause and think about that. That's 8 minutes, one viewing of 8 minutes, and there is no physical treatment that will give those results at 2 weeks. So I think we don't have to be showing a video, that we just have to take these concepts around education and understand that pain catastrophizing, fear avoidance, kinesiophobia are all significant and regular features in patellofemoral pain, and I believe have absolutely been really highlighted and elevated in COVID with this background culture across the population of anxiety and this alteration in pain processing through change in routine and sleep. So I think we can take those 5 elements, can't we? We can all do that, and we can easily integrate that into our clinical practice. And I think, you know, the longer I've gone along since qualifying, the more confident I've been in taking time to educate and talk to the patients. We don't have to be doing every minute of the consultation. It's okay to take a step back and say, you know what, I'm going to spend this time really empowering the patient, really educating them. And as I say, you know, you will never find a study looking at physical outcome measures that have those results after 8 minutes at 2 weeks. So also, if we're time starved, you know, that is also another thing, is that we can say this is a time efficient treatment as well. So I want to move away now from the top of the triangle, which was obviously the CNS, to the bottom left-hand corner of that pain and movement reasoning model, to looking at regional influences. So I have had loads of my old patients coming out of the woodwork. So that means, you know, just reappearing, having not seen them for a few years. And it's happened enough that on my reflections, I have thought about, well, why is this? What's going on with, you know, and my conclusions are as follows. We know that cartilage is designed to deal with compression, compressive load. But it doesn't particularly like shear. We know that the patellofemoral joint, when the quadriceps are weaker, exhibits more instability. So it's not necessarily dislocating, of course, but just that slight extra movement sideways between the patella and the trochlear because of a loss of strength can create shear and can create subchondral bone edema, which will be painful. So we want the quads to be strong because it means that we don't have the shear. And also what's been shown is that when you have bigger muscle mass in your quads, we have the load spread across a bigger surface area. So of course that's great because then we have less pressure per centimetre squared. And the VMO architecture, the field around the VMO has really moved away from the concept of working it in isolation. We can't work it in isolation. That is impossible. You can't selectively recruit it. So we need to move away from the concept of talking about that. But my research in the last decade has looked at the architecture of the VMO. And so what I mean by that, quite simply, is the angle of the VMO fiber relative to the femoral axis. So really think about it as relative to the femur. So what angle does the VMO come in at? And we can measure that accurately on ultrasound. So we've looked at this and shown that people, when they are atrophied, have a small fiber angle around 40 degrees to the femur. And conversely, when someone hypertrophies, we get this spreading of the VMO around, and the VMO then sits at around about 70 degrees to the femoral axis. So then becomes much more medializing with its direction of force. We've also shown that the amount of the medial border of the patella will alter depending on this as well. So if you're weak and you've got an atrophied VMO, you're likely to only have about a third of the medial border with a VMO attachment. And those very athletic people that have a large hypertrophy VMO will have attachments right down to around 95% of their medial border. So therefore, again, the VMO, when it's firing as part of quads exercises, will be more medializing. So it explains again why when people have stopped suddenly in their tracks, regular gym users, or people will say playing regular tennis or whatever it may be, and their exercise profile has changed radically overnight, that they will have a less favorable architecture for supporting that patella, and they're more likely then to develop patellofemoral pain. And the sitting, you know, I mean, people have just been sitting for such big volumes. This paper's just come out, shows that unsurprisingly, 61% reported increase in musculoskeletal pain working at home during the pandemic. And of course, that's not just patellofemoral pain. And I think the number one was actually back and neck. But all the sitting, all the being sedentary, let's think how else that is relevant in patellofemoral pain. Well, if you're sat for bigger volumes because you don't have your commute, you don't have that regular walking across the office to speak to someone or going to the photocopier or whatever it may be, if you're sitting for bigger volumes, you're going to encourage those hip flexors to tighten. So modified Thomas test. So if we're going to do a modified Thomas test, make sure we have a nice flat lumbar spine by bringing the other limb up. And then we're going to look at the hip angles. So here in this picture, the right limb is neutral hip. If we saw that femur raising up towards the ceiling, then that's suggestive we've got tight hip flexors. If we flex the knee passively and the hip comes up into hip flexion, there's only one structure that crosses the hip and the knee when you're testing this, and that's rectus femoris. It's implicating rectus femoris. We can also even add in hip adduction to look at tightness on the lateral side. But primarily thinking about this concept of sitting, if we have someone that's suddenly sitting more and they've lost their hip extension, it's been shown in pre-pandemic literature that in your gait cycle at toe off, when you should be in hip extension, if you can't get into hip extension, well, what happens? You have to flex your knee to get to that toe off part. You've got to do the movement from somewhere. So if you are at more knee flexion at toe off, you are more likely to have bone marrow edema in your patellofemoral joints. And we know there's plenty of literature to help us show that if we have weaker glutes, which let's face it, if we're just sat on them all day, they're not going to be strong, then we're going to be more at risk of excess movement in the frontal plane, so pelvic movement. We're going to have potentially excess and uncontrolled movement in the horizontal plane, so femoral rotation. Both of those really undesirable for patellofemoral pain. So we can look at doing proximal strength programs. So just because someone's working from home, and lots of people are still working from home, a lot more than pre-pandemic. So saying, okay, well, you're going to be sat because you're sat working, but let's look at some strategies around that. So perhaps let's look at a proximal strength program, and seeing if we can also educate around movement control. So just because you're strong doesn't mean it's going to give good movement control. So what are we after? Well, we're certainly not after excess femoral internal rotation. So something again to be aware of, particularly perhaps with kids, is sitting with knees together, feet wrapped around the chair, legs. So that's something that is just constantly bringing those hips into internal rotation, stretching out the external rotators. So we don't want gluteal weakness, and we need to work with the patient to create an exercise program that isn't going to overwhelm them, particularly in that, if we go back to the anxiety, if there's a background of anxiety, then let's just look at 2 or 3 exercises, alternate days to fatigue, and that will do the job. That will be sufficient. So let's think here, you see, we could assess in single stance. So we could just ask someone to stand on one leg, and what happens? We want a nice level pelvis. We don't want that pelvis just dropping. And if it does, are they aware of that? Can they correct it? Do they hyperextend at the knee for stability? Do they lock back? Are they holding on with a hand like this, bracing their legs together, which are all strategies to try and stabilize? So we can look at what their movement's like in single stance to start getting a snapshot of control in that frontal plane. And Lee Harrington's work, and Lee's given permission for me to use this and also for you to use this, he's validated this as a qualitative analysis of single leg loading. And I really like this because it moves us away from just saying wobbly and single stance, which I get lots of letters that say something like that, to a very pragmatic, easy way of actually saying, well, what is wobbly? Is it that it's all arms, so arm strategies you can see there, or actually they're arms still, but it's all the trunk moving around, or actually is that all quite quiet, but it's the pelvic movement? And if so, is it in the horizontal plane? And then coming down, actually all of that might be still, and then it might be that their thigh is whizzing around either into adduction, or it might be into internal rotation, which then alters the knee position as the knee is swinging in. And can they do it? Or do they need to touch down with the hand, touch down with their other foot? So what this gives us is it gives us a way of objectifying, but in a way that's easy to do. You need nothing, you don't need any equipment. It doesn't take ages. You know, I'm a total pragmatist. If you've got to get loads of equipment out and spend time setting it up, before you know it, your treatment time's gone. So this is a really nice way. And then it also means when you give your stability exercises out, you can say, look, this, and this, and this were all fine, but your arms are all over the place. So I want you to really focus on keeping those arms quiet when you're standing on one leg when you're practicing this at home. Or actually, your top half's nice and stationary, but your thigh is swinging around. And I often say to the patients, think of your patella, your kneecap, like a headlamp on a car. We don't want it swinging around wildly. We want it just facing forwards. So think about that, maybe using mirrors to help. And we can look at the photographs here, which help to show what we're after, optimal and suboptimal. And again, you can use these with patients to show them nice positioning, nice stability, and undesirable. Okay, so very pragmatic, but very applicable. And there is actually also research in patellofemoral pain to help us with the trunk. And this paper from 2016 revealed that trunk activation in single calf raise, so in a situation that brings in instability, is altered and shows deficit in patients with patellofemoral pain. So, you know, if you stand them on one leg and it's all happening, wobbling around at the trunk, it's okay to give them a trunk strength program. It's probably exactly what they need. And of course, you know, linking this back in with the whole issue around the pandemic, all of that sitting and reduction of exercise, of course, doesn't just drive deconditioning in the legs, it's going to drive deconditioning in the trunk as well. So let's move on now to load. Well, so we've actually been talking about loss of load, haven't we? Loss of the gym, loss of exercise, but of course it's gone the other way too. And I have had plenty of patients who've rather sheepishly said, yes, going from doing no exercising to running every day probably was a bit much, wasn't it? So they kind of even know before they come in that often what they've done really wasn't the wisest. So let's look at what's happened. So there's been an explosion of people doing home videos. So not only is that an issue around volume potentially, but it's also an issue around technique. No one watching over them, whether they're doing multiple squats very badly, obviously often landing on, if they're jumping around, landing on inappropriate flooring, and very often have gone from nothing to every day. And that change, it doesn't mean that people can't exercise every day, but it's the rapidity, it's the speed of that change that's the issue. There's no time for adaptation. You know, the body will adapt over time to load, whether it be cartilage, whether it be bone, muscle, tendon, it will all adapt, but it needs, of course, that time to do that. And also people exercising with fatigued muscles, if they've gone from not being used to exercising and then they're exercising every day, then they're going to be exercising with fatigued muscles. So these are all issues around too much new unaccustomed exercise. And we can again draw from the pre-pandemic literature. So Esculia is in Canada and he's done lovely work on running education, but I don't mean fine movement education. So looking at advising people on whether they should run through pain or not, training loads, warm-ups, cool down, days off, all of this sort of stuff, and has shown how effective that what might seem to some as quite basic education can be. And we need to think about, particularly with running, problems around when people run and do nothing else, there's no strength and conditioning alongside it, speed of build-up of mileage, lack of rest days, lack of route variety, especially downhill. Downhill running is one of the most fearsome things that you could do to a patellofemoral joint. So we need to be thinking as well about talking to the patients about the routes if they're running. Lack of endurance, have they got enough endurance? And they might set off and be running and moving with good form, but actually by the end of the run, their pelvis might be like this, the femurs might be medializing because they haven't sufficient endurance to move well throughout the whole of the run. And what footwear are they? Are they just putting on a pair of Converses and running? I mean, the stories that I've heard during the pandemic around what people are doing and their desperation to do something and keep fit. And that really actually fits with the last point on this slide. It may seem to you as an exercise and health professional so obvious that you wouldn't run in a pair of Converses, or that you wouldn't just run on a hilly route every day, having never run before. But it isn't necessarily obvious to the patient. And this is what Esculia's work is around. It's just sort of basic common sense advice so that people can manage their running load well. And I think we don't have to just think about that with respect to running. I think we can apply that to any sports, particularly when people are taking them up. So sticking with load, but changing slightly now onto footwear. So this is another thing I always have been aware of the role of footwear in patellofemoral pain. And I'm sure some of my patients must think that I'm obsessed about shoes because I'm always asking people about footwear and whether it changes their pain and is it a high heel, and if so, if it's a thin heel or a wedge or what it is. But I think, again, people have been padding around barefoot or in socks when that's not what they normally would do all day. And what does this mean? Well, lots of people now have hard flooring at home, don't they? Wooden floors, tile floors. So there's no shock absorbency. And if they're used to a shoe that has a little bit of shape and then suddenly, or they're an orthotic, and then suddenly they're padding around barefoot or in socks, slippers, they've lost that orthotic use, or that little bit of support. And if you're barefoot, your knee will just go back another degree or two into extension or hyperextension. And I've seen quite a few patients with infrapatellar back pad problems, and I think that big part of it has been set off by them walking around with no shoes. And of course, if you have a tight calf and you normally wear a little bit of a tip from back to front, then the tight calf isn't such an issue. But then if you suddenly walk around barefoot with a tight calf, it's difficult to dorsiflex. You can't get over the foot. So it will encourage you to excessively pronate. And of course, we know excess pronation creates compensatory tibial rotation, and we don't want that for the patellofemoral joint. So yet again, my reflection is, yes, this is really relevant in patellofemoral pain, because a sudden change in it has brought patients knocking at my door. Now I want to finish off with looking at pain from COVID itself. So of course the literature is very recent, it's very much in its infancy, but considering that, I mean, to give you an idea, if you put in musculoskeletal pain, COVID-19 into PubMed from this year, I think there were 46 papers came up. So, you know, there's a lot of literature coming through, which is great. So this first paper here that was published this year looked at mild to moderate COVID-19. So we're not talking about patients on intensive care. We're not talking about even patients that are hospitalized. And of 159 subjects, nearly 72% had either myalgia, headaches, neuropathic pain, or polyarthralgia. So we need to be on our toes for this. We really do. You know, if 49%, if every other patient with mild to moderate COVID symptoms is presenting with and reporting myalgia, we need to be aware of that. And of course, none of us have been taught about this at physio school. Maybe perhaps those of you students are being taught about it. I'd be interested to know that actually. But this is a rapid change in our role as health practitioners and our awareness that we need to have. So of course, unfortunately, we can't really draw on the literature yet about treatment because it's also recent. The literature body is around, hey, this is happening. Big numbers of people are having joint pain and muscle pain, neuropathic pain after COVID. So there are some case studies coming through suggesting that we might want to use quantifiable outcome measures as always. And we might be looking towards graded exercise and pacing as good treatment modalities. And of course, it's not just long COVID that is interesting here. It's also what has happened to those patients who perhaps had some musculoskeletal pain pre-COVID. And this paper from Japan, big cohort, 1,254 patients in this study. And a third of them reported a measurable decrease in quality of life. The largest was through increase in pain. Second largest feature was from decreased mobility. And of course, perhaps no surprise, those two were linked. So those with decreased mobility had the largest reduction in quality of life through a change in their pain profile. So we need to also think that people that were already sort of in the system, if you like, or not even in the system, but had symptoms, have perhaps seen an escalation. Now that might be, if you think back to that triangle, that might be because of their increased anxiety and depression. It might be through change in mobility. It might be through change in mobility and hence weakness. We haven't got all those answers yet, but it's interesting to note that the COVID experience has potentially escalated and accelerated those patients' decline. So to conclude, I have tried to give you an insight into my reflections from the last year. I think there's lots of lessons learned. And for me, it's confirmed the importance of load. Absolutely, probably number one. Exercise, of course, that it links in with the load, shoes, and also definitely let's not forget that psychosocial side, the anxiety and depression. So look, I know for many of you treating patients regularly, this won't necessarily produce lots of new information for you, but sometimes it's good just to stop and think, and maybe it validates your practice, validates what you're already doing, and that's really worthwhile, I hope. And then, you know, let's finish with that quote we started with. Reflective practice is the antidote to complacency, habit, and blindness. It's hopefully a good reminder of what a valuable tool reflection is, and that we all need to make sure we take our time out to be reflecting in practice and reflecting on practice. Thank you all very much for listening. I really appreciate your time. So Tarina, have we got any questions? Okay, here we go. Regards to regular knee joint clicking on sudden movements, either knee flexion or extension, is it a significant finding and can it be an indication for joint damage? Okay, so we're talking about crepitus, a lovely topic for me to talk about because it's an area of my research. And I did qualitative research on this and it has since been quantitative. And what I would absolutely say is that my research and the subsequent research shows that it is not indicative of joint damage. It does not increase, if you've got crepitus, it does not mean you've got increased odds of ending up with a knee replacement. And you need to counsel your patients to separate in their mind pain and noise because they're not the same phenomenon, and manage their expectation from the start that the pain we're going to try and address, but the noise may remain, and they should not alter what they're doing, whether it be physio exercises or their own exercise, because of the presence of noise. Okay, do you have any go-to exercises for offloading the fat pad initially in line with other modalities such as taping? Okay, so exercise for not necessarily for offloading the fat pad, but what I would say is I would not be exercising into full extension if you've got a fat pad problem. And so I'm keen to ultimately give them good control around zero so they don't flick and accelerate into extension or hyperextension. So therefore my starting point might be quite a lot of isometric work around 20 to 30 degrees, so nearby but not in the vulnerable range. And then as hopefully the fat pad settles, you can then creep back towards zero. Okay, next question. Are there any recommendations of surfaces they should versus should not exercise on for those with patellofemoral pain so as to minimize any exacerbations? Well, this is interesting because a lot of people think, oh, knee pain, go onto soft surface. But actually, if you discovered with your patient, particularly perhaps the younger patients, that they've got poor movement control, so perhaps their foot's around, they've got a lot of tibial rotation, femoral rotation, trunk movement, whatever you found in perhaps your assessment in single stance we talked about, don't then add more instability into the equation by getting them to run on sand or grass where they've got even more to control. Okay, so if it's a movement control thing, put them onto a firm surface. If they have got subchondral bone edema, then those are the patients that will be better in cushion shoes, cushion surfacing. Okay, next question. Are there any special considerations in treatment for conditions like Osgood Schlatters? And did you use graph paper for your triangle? Okay, the triangle, no. I don't use graph paper, but I just draw a triangle. The model, the purest version in the literature, of course, uses it as in research you'd have to, but in clinical practice, no, it's just a triangle on a piece of paper. And the Osgood Schlatters, yes, there's been very recent literature in the last 2 years around this, particularly 2020, the beginning of 21, there was literature that came out of Denmark looking at really load management for Osgood Schlatters. So what I do is I have a grid and it says before school, morning, lunchtime, afternoon, early evening, and I get them the weekend as well, and I get the child with their parent to fill in what they're doing when, because often they're not necessarily elite, but they're those sort of sporty kids who might be doing a bit of school netball, school hockey club outside, maybe a park run with dad, keep fit session because it's fun. And when they write it all out suddenly in black and white, it's very obvious how much they're doing. And then I say, look, if you don't address the volume of loads, it's going to force your hand. So which is your least favorite here? Or which one doesn't matter for you? Perhaps have a few weeks out to try and rein back a little bit, or even what positions they're playing on the netball court, on the football pitch. Can they change positions to one that isn't quite such high volume of running? So very much all around load management. So another question, what recommendations can be made to patients who have mild knee pain but want to lose some weight using running exercises? Okay, so if it's mild, it really doesn't have to, they don't have to stop running, but I would certainly not be wanting them to run every day, so perhaps look at every other day. In terms of mild, I say, look, if it's up to a 3 out of 10 and it's settled within an hour afterwards, that's okay, because that's not setting off an inflammatory response. So every other day, no downhill running. And then we can also look at things like stride length. There's good literature to suggest getting a shorter stride length, in other words, increased step rates, is a great way of getting less patellofemoral load and less fatigue on the muscles that we're concerned with in patellofemoral pain. So it's okay to run, it's just how we do it.
There's one question, any opinion on dual action knee braces?
Yeah, I tend to stay away from knee braces, but the one that I use, 2 knee braces in my practice. One is stabilizing brace if I've got somebody with not a dislocating patella, but an unstable patella. The other brace that I tend to use is if they've got very identifiable lateral patellofemoral bone marrow edema. So not widespread, but very much on that lateral patella or lateral trochlear. A Q brace, which pushes the patella medially and encourages better quads activation. It can be a really useful tool. And there is research to show that's Michael Callaghan's work has shown that if you wear one of those, I think his subjects on average was something like 7 hours a day for 6 weeks, they showed a meaningful reduction in bone marrow edema on MRI and pain. So they're the 2 braces I tend to use.